Assalamu alaikum everyone. My name is Junaid Faree and I am a final year student, and thank you so much sir for giving me the chance to speak on the stage. So let me start our today's presentation. So here we have first MCQs. A 35-year-old woman comes to the office due to 3 months of progressive dyspnea on exertion, non-productive cough and fatigue. Mentox test is negative. She is non-smoker. Biopsy shows non-caseating granuloma. What is diagnosis? Option A, sarcoidosis, tuberculosis, syphilis, cat scratch disease. So who want to give the answer of this question? Okay. Only tell the what are the clinical manifestation we can see on it.
In this case, there are the progressive dyspnea, exertion, non-productive cough, fatigue, and the non-caseating granuloma is all the features of sarcoidosis.
Okay. So, what is the causative agent for the cat scratch disease?
This is a virus.
Anyone know about it? What is the causative agent for cat scratch disease? No one? So, the causative agent for cat scratch disease is Bartonella hanseae. Okay. So here the patient likely has sarcoidosis, a chronic multisystem disorder characterized by the epithelioid macrophages multinucleated formation of non-caseating granuloma. It typically affects young adults and is more prevalent in African American individuals and in women. Any organ can be affected, but the lungs are initially involved in most cases. Patients often have the insidious onset of respiratory symptoms like cough, dyspnea, chest pain accompanied by fatigue, fever and weight loss. The disease may also be incidentally detected in asymptomatic patient with typical chest X-ray findings. So here we have second MCQs. A 54-year-old man comes to the office due to pain in the right upper quadrant, nausea and unintentional weight loss. There is a spiral icterus. Biopsy of the bile duct reveals columnar cells with hyperchromatic oval nuclei with prominent nuclei arranged in glandular structures. Mucin production with surrounding desmoplastic reaction is present. Medical history shows ulcerative colitis. Which of the following is mostly likely diagnosis? Cholangiocarcinoma, focal nodular hyperplasia, hepatocellular carcinoma, hepatic adenoma. So, who want to give the answer of this question? Okay, Uzerbi. Uzerbi, first tell us what are the clinical manifestations we can see on this, then step by step how it will be approached to the patient.
Firstly, if you look at the constitutional symptoms here, in the constitutional symptoms we've got the pain in right upper quadrant, we've got nausea, we've got unintentional weight loss. Then if we come to the clinical findings, we've got the scleral icterus, and if we go to biopsy, we've got a columnar cell with a hypochromatic oval nuclei with prominent nuclei arranged in a glandular structure. And the most important thing here is ulcerative colitis. So I will go for cholangiocarcinoma. My reason for cholangiocarcinoma is because ulcerative colitis is highly associated with primary sclerosing cholangitis. And primary sclerosing cholangitis, if unfit, can lead to cholangiocarcinoma. So that's why my answer is cholangiocarcinoma here.
So, 40-year-old patient comes to the emergency department after severe pain in right iliac fossa for 3 days and fever. Blood pressure is 80/60 millimeter of Hg. CBC shows leukocytosis. Complete blood count show leukocytosis. Ultrasound reveals fluid in right iliac fossa. What is the most likely diagnosis? Appendicitis, acute pancreatitis, intestinal perforation, acute cholecystitis. Anyone to give the answer of this question? Anyone? Miraj Abid.
It's appendiceal abscess.
Okay.
It's a perforation of the appendix.
Don't go for the diagnosis. First, see what are the clinical features we can see on this patient.
Blood pressure is normal.
Normal?
Low. Blood pressure is low.
Okay.
CBC show leukocytosis.
Okay.
And ultrasound fluid pass. It means pass in the right iliac fossa.
Yes, exactly.
And what is most likely? That's why it's in right iliac fossa. Mostly we see the appendix. Maybe it is due to the appendicitis, perforation of the appendicitis.
Okay. Anyone? Anyone else? Okay, exactly.
So now, if we go step by step in explaining this, so the first thing is that it is severe pain right iliac fossa. So we've got right iliac fossa organ, so we'll go for appendix now. Then we've got a fever, which also is a very confirmative of abscess, and then we've got presence of pus. So basically, it is an appendiceal abscess, and severe pain can be due to the rupture of that appendiceal abscess, which can lead to the fluid in the right leg fossa region. So it is a case of appendiceal abscess because one is the location,
Yes.
then there is the pain and the fever.
Exactly. Thank you so much. So that's what we have appendiceal abscess. Okay. 25-year-old female in his last trimester comes for follow-up. Her blood pressure is 150 by 100 millimeter of Hg. After 4 hours, his blood pressure was re-evaluated and was 140 by 90 millimeter of Hg. There is no end organ damage. What is the most probable diagnosis? Chronic hypertension, gestational, pre-eclampsia or eclampsia. So, anyone want to give the answer of this question? It's we can see the blood pressure. Okay, Imran.
Gestational hypertension.
Yes. What is the normal range of gestational hypertension?
In the gestational hypertension, after before 20 week of the gestation, the systolic blood pressure is more than 140 millimeter of mercury, and systolic blood pressure is more than 90 millimeter of the mercury.
Exactly.
And we measure the two times after 2 times consecutive after 4 hours of the interval before the 20 week of the gestation. This is a gestational.
Okay, exactly. Can you tell me why we take two values? Two separate values.
Two separate values.
Yes, in 2 hours of time.
And to evaluate the changes of the hypertension, to differentiate whether is it the eclampsia, preeclampsia, and also to evaluate the other eclampsia and preeclampsia conditions.
Okay, thank you. 25-year-old male with bloody diarrhea was diagnosed with amoebiasis. To infect other, what will be the found in the water contaminated with his feces? Okay, so which amoeba infect here first? Anyone wants to give the answer of this first? Which amoeba? Okay.
Amoeba histolytica.
Yes, Entamoeba histolytica. So, answer A, trophozoite, cysts, eggs and larvae. So basically we have Entamoeba histolytica having two forms, trophozoites and cysts. But we have the active form of cyst that is growing and most commonly found in the contaminated with feces, water with feces. Okay? Enterovacuum has two forms, trophozoites and cysts. Both are secreted in feces. Cysts have the ability to survive in outside environment and thus has the ability to infect others. Okay? So 27-year-old male with history of IV abuse comes to emergency department with low-grade fever, myalgia, headache, tachycardia and night sweats. Examination show splinter hemorrhage, now onset, hollow systolic murmur and oscillatory nodes. What is the most likely diagnosis? Mitral valve prolapse, hepatitis C, infective endocarditis, pericarditis. Okay. Now who wants to give the answer? Or I choose. Okay. Abbas. Abbas, first go for the clinical features. then step by step.
low grade fever, myalgia, headache, tachycardia, mad sweats, and on examination we have a splinter hemorrhage and ulcer node, and Hurl's systolic murmur are seen in the infected endocarditis.
Okay.
So I would use infected endocarditis.
Okay. What is the most common bacteria that is affecting on this? Streptococcus or Staph aureus? Yes. Okay. Thank you. So here we have we can see the ossular nodes and splinter hemorrhage. Like we have other symptoms. Ossular nodes most commonly seen in the infective endocarditis. Okay. 55-year-old patient comes to the emergency department due to recurrent episodes of palpitations, dizziness, and lightheadedness. ECG shows complete dissociation of P wave and QRS complex. Third-degree heart block is diagnosed and pacemaker is implanted, which structure is abnormal in this patient. SA node, AV node, Purkinje fibers, ventricular myocardium. Anyone want to give the answer? Or again I choose? Uzarbi.
So it is, we've got EV block, ventricular block. Basically the EV node is situated such that it transmits the impulses from the atrial area to the ventricular portion of the heart. Here what we have is that the P wave and the QRS association, basically when there is the impulse does not goes directly from that via the EV node from the atrial to the ventricle, which we have the we can say the ventricular function and the ventricular contraction are impaired, which will lead to these ECG changes. So the EV node is the main culprit. So we will go for EV node implantation.
So Larry, it's very good. You explained so well. Can you tell us what is the AV when there is a problem of AV node?
Yes.
Then it is asymptomatic or having some symptom?
We will have in AV node it depends. So we got like one is the AV blockage in which we have of course we have a ventricular bradycardia sort of that.
Bradycardia.
But
Yes.
if in case in some cases when we've got the iron dysfunction like in hyperkalemia, in that case you got the AV shooting which lead to
Yes.
supraventricular tachycardia. So in this case you get bradycardia.
Exactly. Very good. Thank you so much. So, first year. The ratio of median toxic dose to median effective dose is called therapeutic aliens, therapeutic window, therapeutic index, bioavailability. Anyone wants to give the answer of this? Okay, Nasir. I think bioavailability. So why intravenous bioavailability is 100? We studied in the first year. It is absorption. Okay, no problem. It is basically median toxic dose over median effective dose. It is in the therapeutic index. Or what is, you can tell me therapeutic aliens and therapeutic window. What is? Okay, let me explain. Therapeutic aliens, basically it's a therapeutic relationship, doctor relationship with the patient or like this. And therapeutic window, time range between the injury and treatment, during which treatment is still effective. Okay. So, therapeutic index is the measurement of the safety of the drug. Its formula is T1, TD50, ED50. Greater the therapeutic index, the safer of the drug, higher therapeutic index. Glucocorticoid, penicillin, narrow therapeutic index. Drugs with narrow TI require monitoring. Lithium, etc. Okay. A 22-year-old man comes to the office due to the recurrent development of small itchy spots that lately has had large blisters that heal with hyperpigmentation after rupturing. He drinks 2 to 3 cans of beer daily. Which of the following enzyme is mostly likely deficient in this patient? Uroporphyrogen decarboxylase amino livulinate dehydrase or what is the full form of it? Okay, porphobilinogen deaminase bilirubin glucuronide transferase. Anyone wants to give the answer of this question? Anyone? Okay, Adnan.
First, I will like to ask what is PBG3 aminase because this
Porphyrobilinogen deaminase. Basically, these are the enzymes. These are the enzymes that converts. Like we have studied the fate of RBC like that. So it is mainly production of the iron.
Thank you for the answer. This is answer.
Okay.
This is answer.
Yes. So here there is small mistake from my side. Wrong answer is put in here. So option A is the right answer here. Uroporphyrogen decarboxylase. Okay, basically porphyrocutania tarda is the common disorder of porphyrin. It's a common disorder of porphyrin and porphyrobilinogen photosensitivity present as vesicle and blister form. Here we can see that there is a blisters that heal with the hyperpigmentation after rupturing. So basically it's due to the hypersensitivity. There is a vesicles, blister formation or such exposed areas as well as edema, pruritus, pain and erythema in the patient. A 59-year-old man comes to the office due to 3 months of progressive fatigue and back pain. The back pain occurs mainly with movement of positional changes. Laboratory evaluation shows a hemoglobin level of 10.2 gram per deciliter and serum calcium level of 12 milligram per deciliter. Urine analysis shows 4 gram per day proteinuria. What is most likely diagnosis? Multiple myeloma, nephrotic range proteinuria, parathyroidism, hyperthyroidism. Anyone wants to give answer of 35 questions? Anyone? Haris?
According to history, there is 3 months of progressive fatigue, back pain, and back pain is
Haris?
back pain with positional changes. So, when analysis is 4 gram per deciliter proteinuria is considered. So, intention is 12 milligrams. So, I will go for the multiple myeloma.
Okay, that's great. Haris, can you tell us what is the normal age of calcium? Calcium level? 8.6 to 10.3. Exactly. And can you tell us, please, which anemia is mostly likely here? Most likely here.
There is dilution anemia.
Normocytic.
Proteinuria, excess of proteinuria.
Yes.
So,
So
normocytic anemia, you can say like there is no
normocytic, normochromic. Yes, exactly. Very good. A very good explanation explained by Haris. A 35-year-old woman comes to the office due to the frequent urination and unquenchable thirst. Water deprivation test shows no change in urine osmolality. This improves after administering desmopressin. What is most likely diagnosis? Central diabetes insipidus, nephrogenic diabetes insipidus, primary polydipsia, diabetes mellitus. Okay. Anyone wants to give the answer of this question? Arslan.
Central diabetes listed.
Okay. Why we choose this option?
Because due to excessive ADS secretion, frequent urination.
Okay, in diabetes insipidus, we have seen three things. What are those features?
Polyuria,
Yes,
polydipsia,
polydipsia, and last one. Polyuria, polydipsia, and last one. Very good. So here the right answer is A. Diabetes insipidus is caused by either ADH deficiency or a complete partial unresponsiveness of the kidney to antidiuretic hormone. The end result is free water loss in the urine with production of dilute urine, and dehydration that causes excessive thirst. A water deprivation test with desmopressin administration can differentiate between central and nephrogenic diabetes insipidus. In patient with central diabetes insipidus and complete nephrogenic diabetes insipidus, the urine osmolarity is persistently low despite an increase in the serum osmolarity with water deprivation. When desmopressin is administered, patient with central diabetes insipidus show a rapid increase in urine osmolarity and reduction in urine volume. Okay. How acute myeloid leukemia can be differentiated from acute lymphoblastic leukemia histologically? Option A, presence of TDT, presence of air rods, and CD markers can't be differentiated histologically. Okay. Fun. Yes. So now we have basically main difference is all rods is present here and MPO positive is here. AML is differentiated from ALL by the presence of rods as are seen under microscope. Rods are pink, red, rod-shaped granular cytoplasmic inclusion bodies in malignant immature myeloblast or myelocytes. Myeloperoxidase, MPO positive is here. So here we have case a 24-year-old woman, gravida 1, para 0 at 14-week gestation comes to the emergency department due to the left leg swelling and pain with mild arrhythmia for the past 2 days. Doppler ultrasonography shows left popliteal and femoral vein thrombosis. Serum creatinine level is 0.7 milligram per deciliter. Which of the following is the most appropriate pharmacotherapy for this patient? Epsiban, clopidogrel, dabigatran, and enoxaparin. So, anyone wants to give the answer of this question? Okay, Hasanaki. Which? Clopidogrel. Okay. Anyone satisfied on Hasanaki answer? Wajahat.
Over here we can see more antibiotic than like Izaban and enoxaparin. But if we see that she's pregnant, so the drug of choice would be
Which drug?
enoxaparin.
Enoxaparin. So anyone tell us why we will give enoxaparin? Yes, please, Adnan.
Because this is a low
Please
molecular weight heparin. That's why we
Yes.
always fast hyperlyze the patient.
Exactly. Can you tell us what are the physiological hypercoagulability stages? Some of these, like pregnancy,
Yes.
any other?
Pregnancy, polycythemia,
Yes.
OAR.
Polycythemia. Very good. Any other?
High altitude.
Yes. High altitude. Anyone?
Very sure. And
That's great. Okay. Please sit down. Thank you. So, pregnancy increases the risk of venous thromboembolism due to anatomic changes and physiological hypercoagulability, increased production of clotting factors, decreased protein S level, protein S resistant. Heparins are ideal anticoagulant for most pregnant women as they do not close the placenta and the risk of fetal bleeding and teratogenicity is low. That's why we are choosing an exoparin in this case because it is low molecular weight heparin. So here we have a case. An 8-year-old unvaccinated boy is brought to the emergency department due to fever, sore throat and difficulty breathing. Physical examination shows extensive coalescing grey pharyngeal exudate and cervical adenopathy. What is your diagnosis? So, anyone wants to say about it? Okay, Miraj Abid. Miraj Abid, first tell us what is the causative agent for tetanus?
Clostridium tetani,
Yes, exactly. And pseudomembranous colitis?
pseudomembranous colitis.
Clostridium difficile.
Yes, exactly. Okay. Sit down. Zarvin?
Yes.
Diphtheria?
Yes. That is here, but
Corynebacterium?
Corynebacterium bacteria. So,
Okay. Can you please explain?
so you got an 8-year-old unvaccinated boy brought to emergency department due to fever, sore throat, difficulty breathing. These are the main physical examination shows extensive alcoholism in grey pharyngeal exudate. Here, these feature directly go for diphtheria, but if we even go on the, for example, we go on the elimination method. So, for example, tetanus. If a tetanus patient can be, that he's got specific physical examination find like opisthotonus,
Yes.
which is not present here, of course.
Exactly.
We've got pseudomembranous colitis. We have some GI symptoms which are also not present here. Hemophilus influenza, we will have some specific respiratory symptoms which are also absent here. So, and altogether, we've got pharyngeal exudates which are coalescing gray. That is specific for diphtheria. That's why we go for diphtheria infection.
Thank you so much for your nice explanation. Esophageal perforation can be best established after initial investigation by contrast, esophagogram, esophagoscopy with flexible esophagoscope, esophagoscopy with rigid esophagoscope, X-ray, chest with oblique and lateral view. Anyone voluntarily wants to give this answer? Okay, Muzammil. Why? Can you tell us what is contrast esophagogram? In simple words, what is contrast? Okay, sir. Anyone wants? Irfan?
Contrast esophagogram, we use some kind of guide, and
Yes.
then we rely on the CT scan, so that we can establish the exact site of examination and evaluation.
Yes. Like we don't know what is the case. Why we are choosing it as an initial investigation to making the confirmatory diagnosis about the disease.
That it exactly point of the location.
Yes, exactly. So most common cause of vesico-vaginal fistula in underdeveloped country is iatrogenic trauma, obstetric trauma, congenital malformation, malnutrition. Anyone wants to give the answer of this question? Okay, Rahman Sabir. Rahman Sabir, can you tell us what is vesico-vaginal fistula?
Basically, fistula is a connection between two organs. So it's a fistula between vagina and the vesicle. And it is most probably due to obstetric trauma, because in underdeveloped countries there is not the procedures are not done very skillfully. So maybe it will be obstetric
Yes.
trauma.
Okay, please sit down. So, what is vesico-vaginal fistula? Anyone wants to tell about it? Basically, vesico-vaginal fistula is an abnormal opening between the bladder and vagina that leads to the unremitting urinary incontinence. Okay, so here we can see that there is a most common cause is obstetric trauma. Why we are choosing obstetric trauma? Why? Only one reason. Yes. In underdeveloped country, what we can't have that developed countries have.
Lack of skills.
Yes. 22-year-old woman comes to the OPD with mucopurulent malodorous discharge. On pelvic examination, there is a cervical pain and bleeding on manipulation. There is a history of unprotected sexual intercourse with his partner. What is the most likely diagnosis? Okay. Anyone wants to give the answer of this question? Abbas. Okay, Abbas, please sit down. Yasir. Okay, can you want to explain why the option is gonorrhea? Why gonorrhea?
STD.
Yes, exactly. Very good.
Because the bacterium Neisseria gonorrhea leads to the genital tract infections such as urethritis, failure of pregnancy, etc.
Okay. So Shaham, can you tell us what clinical features we are seeing on the clinical picture of this case? We have option like Yasir tell us there is an option of gonorrhea because it's a STI, sexual transmitted infection. So we don't have, these are not a sexual transmitted infections. Okay. So can you please tell us the clinical picture of this case?
Pelvic examination, there is cervical pain, bleeding, and a history of unprotected sexual intercourse.
Okay. So here if we have the patient of gonorrhea that is caused by the Neisseria gonorrhea, so we have purulent vaginal, urethral discharge, dysuria, cervical pain, bleeding on pelvic. Okay, this that we have. Stunting is defined as height for age is more than 2 standard deviations below the WHO World Health Organization child growth standard median. Weight for age is more than 2 standard deviations below the WHO child growth standard median. Weight for height is more than 2 standard deviations below the WHO child growth standard median. Height for weight is more than 2 standard deviations below the WHO child growth standard median. So anyone wants to give the answer of this? Shami. At the Shamula. At the Sham, can you tell us what is stunting?
weight growth.
Yes, very good. What possible causes of it? Due to what there is a stunting growth of the child?
Malnutrition.
Yes, exactly. Poor nutrition. Okay, please sit down. So, Farooq, can you tell us the answer of this question?
Height age is more than 2 standard deviation below the usual height for standard in the middle.
Okay, thank you. Stunting is the impaired growth and development that children experiences from the poor nutrition, repeated infection, and inadequate psychological stimulation. Children are defined as stunted if their height for age is more than 2 standard deviation below the WHO child growth standard median. A 35-year-old presented to OPD with the complaint of fever and weight loss. There is a cyst present lateral to midline, but in front of sternocleidomastoid muscle, aspiration of abscess reveals pus. There is a history of upper respiratory tract infection. What is the most likely diagnosis? So, who wants to tell us only the clinical features? Not the diagnosis, only the clinical features. Who wants to answer? Okay, Arslan Majid.
Patient complaints of fever, weight loss,
Yes.
is present at the lateral to midline in a sternocleidomastoid muscles, history of upper respiratory tract infection, the aspiration rate plus signs.
There is a history of upper respiratory tract infection also.
Yes.
So, what we can conclude according to these symptoms or these clinical manifestation?
Maybe there is some congenital problem with the respiratory system.
Yes.
Thyroid.
So, in this, because this is also a embryological remnant, it is also an embryological remnant. So,
Yeah.
What-
It's related to upper respiratory, so we will go for bronchial and
arch cyst. Because you are saying that here the mention is located.
Sternocleidomastoid muscle also here and upper respiratory tract infection. So we go for bronchial arch.
Very good. Thank you. So, brachial arch cyst is remnant of the embryological second brachial cleft or cervical sinus, which normally regresses before birth. It is formed due to the incomplete obliteration of branchial clefts and pouches. Clinical features are usually diagnosed in late childhood or in adulthood after a previously undiagnosed cyst becomes infected. History of upper respiratory tract infection painless. Firm mass located lateral to the midline, usually anterior to the sternocleidomastoid muscle, does not move with swelling. There may be a small draining opening if a fistula is present. A 50-year-old patient brought to the emergency department with fever, lethargy, and worsening ascites. He complains of diffuse abdominal tenderness. There is a flapping tremor of hands, medical history of significant for cirrhosis. E. coli is found on culture. What antibiotic should be given? Metronidazole, IV metronidazole, IV cefotaxime, IV cefotaxime, IV ampicillin. Anyone? Okay, Aisha. Only tell us what are the clinical features. What is the clinical feature of this case?
Fever, lethargy, worsening ascites, and abdominal tenderness, flapping tremors of the hands, cirrhosis, and E. coli was found on the culture.
So, E. coli causes which disease? Anyone can tell?
Bacterial.
E. coli. causes which disease?
Most from
Yes.
UTI.
Urine tract infection. So, which antibiotic should be given if there is a case of E. coli?
IV.
IV cefotaxime. So, which class of cephalosporin is this? Yes, please sit down. Thank you. Okay. A 30-year-old pregnant woman with previous 2 C-section deliveries is being evaluated for abnormal attachment of placenta. The placenta chronic villi have attached to the myometrium and penetrating it. What is the condition called? Mangash. Can you explain what is placenta accreta, increta, percreta, previa? Only terms. Okay. Anyone wants know about this? Please sit down. Anyone know about this? Yes, Asan, please.
The difference is between the placenta form so it just penetrate more inside into the uterus wall.
Yes.
So it depends on how much delivery it put inside.
Yes.
So the name is
Like- Like we have placenta accreta. It is going up to the where? Like uterine lining or myometrium or beyond the myometrium like bladder or so please explain like this.
Increta is not that much severe.
Okay.
It's like a mild one.
Yes.
Then increta and then percreta.
Yes.
So the percreta is more like
Yes.
go deeper and inside.
Okay. So what is placenta previa?
Placenta previa is like in the placenta forms above like the cervix.
Yes, lowest part of the cervix covered.
Placenta previa.
Please, thank you. So what is the answer of this question? Sorry.
The answer will be placenta increta.
Okay, please sit down. Zarbi, can you tell us what is the answer of this question?
Here it's got placenta increta.
Why?
Because it is just like it is just piercing the myometrium, but it is not going to that late release. That's why like it is at the mid stage. And apart from that, accreta is, as he said, is a milder, in which it is not penetrated the myometrium, and the percreta is already penetrated, and it has gone to the laterally. And placenta previa is when we got the abruption of the placenta, and we can call that, and it covers the cervix partially or completely. It's placenta previa, so here it is increta.
Okay, please sit down. Thank you so much. Defective decidual layer leads to abnormal attachment and separation after delivery. Risk factors are prior to C-section or uterine surgery involving myometrium, inflammation, placenta previa, advancing age during pregnancy, multiparity. So here we have the placenta accreta that is going up to the uterine lining. Increta grows into the wall of the uterus like myometrium. So we have a placenta percreta that is going to the near organs such as bladder and colon. And we have the placenta previa, lowest part of the womb and covers opening to the cervix.